There is a very good reason why we are gathered here today. A key question to maintain future sustainable healthcare system will be how to reduce premature and preventable death caused by cardiovascular diseases. The WHO estimates that 80% of cardiovascular diseases could be prevented. I think there is a reason for decision makers to try new approaches, to think in new terms. During my time as Minister for Health and Social Affairs in Sweden, we created a new strategy and reformed the structure of cancer care in Sweden. This in turn meant a review and increased attention to an area where was undoubtedly great potential for improvement. I think there is a lot of evidence that the field of cardiovascular diseases would similarly benefit from a fresh start and a new strategy. So, welcome to the Healthier Heart seminar, a platform for dialogue and exchange of experience within the European Union. We will get to listen to many prominent and committed speakers. Already, early in the program, I would like to welcome questions to our knowledgeable panelists who will participate during the afternoon. Please take the opportunity and ask your questions via menti.com on your telephones and the code that you can see on the screen. I hope you put some questions forward, and I'm sure the speakers would like to answer them. We are proud that the Swedish Minister for Healthcare, Acko Ankarberg Johansson, the Swedish Minister for Healthcare, wants to address our conference with introduction remarks. And immediately after that, we will hear from John Ryan, Director, Acting Deputy Director General at the Commission's Directorate General for Health and Food Safety. Please, Minister.
Hej och varmt välkomna till seminarieeftermiddagen Healthier Hearts som jag har fått möjlighet att inleda. Först vill jag säga att jag tycker det är fantastiskt att kompetens och expertis från olika länder samlas här i Stockholm för att diskutera och utbyta erfarenheter kring de här stora frågorna som folksjukdomar är. Folksjukdomar som påverkar och är viktiga för så många människor. Och det påverkar förstås mitt uppdrag som sjukvårdsminister också. Hjärt- och kärlsjukdomar är idag den största enskilda orsaken till död och ohälsa i Sverige liksom i Europa. Och ni som deltar på den här konferensen idag utgör en viktig del i att förändra det. Förutom att hjärt- och kärlrelaterade sjukdomar medför lidande och sorg för den enskilda individen, för familjer och berörda, så är de här sjukdomarna också resurskrävande och kostsamma för hälso- och sjukvården och för samhället i stort. På Socialdepartementet är jag glad över det goda och nära samarbetet med min kollega Jakob Forssmed, socialminister. Han ansvarar för frågor som rör folkhälsa och åtgärder som förebygger insjukna sjukdom. Fysisk aktivitet på recept, fritidskort och gemenskapssatsning är några förslag som socialministern har presenterat och som bidrar till en bättre folkhälsa och förebygger insjuknande sjukdom. Vi har på många sätt en fantastisk sjukvård i Sverige. Vi har en hjärt- och kärlsjukvård som håller hög medicinsk kvalitet och en fantastisk vårdpersonal som gör otroliga insatser varje dag. Men för att vården ska fortsätta hålla hög kvalitet krävs också forskning och utveckling och att ny kunskap tas tillvara. Forskningen har möjliggjort fantastiska framsteg i behandlingsmetoder som både ökar chansen till överlevnad och god hälsa efter insjuknande, till exempel hjärtinfarkt, samtidigt som det minskar behovet av inneliggande vård på sjukhus. Koronarangiografi och PCI är kanske det främsta exemplet på hur klinisk forskning kan bidra till så tydliga förbättringar av sjukvården och för folkhälsan. För att vården ska bli mer jämlik så behöver nya behandlingsmetoder spridas så att det kommer alla patienter till del, till alla som är i behov av dem. Tillgång till rätt kompetens är ju en förutsättning för detta och därför arbetar regeringen intensivt med att bygga bra förutsättningar för en långsiktig kompetensförsörjning i hälso- och sjukvården. Sverige har haft stor nytta av våra kvalitetsregister. Vi vet också att kvalitetsregister som exempelvis SwedeHart och Rikssvikt har bidragit till goda grunder för forskning och innovation samtidigt som det hjälper att skydda patienter från allvarlig sjukdom och död i hjärt- och kärlsjukdom. Sådana register räddar faktiskt liv. Och de är exempel på när vårdnära administration kan användas på rätt sätt i syfte att förbättra vården för så många människor. Därför är jag också glad och stolt att svenska representanter kan bidra med erfarenheter och kompetens i uppbyggnaden av det europeiska hjärtregistret Hearth. För det finns mycket som varje enskild aktör kan göra inom sitt kompetensområde för att hjälpa och underlätta på individnivå. Men när det kommer till att göra strukturella förändringar och att minska hjärt- och kärlsjukdom på befolkningsnivå så behöver vi samarbeta mellan olika aktörer på nationell nivå men också mellan olika länder. Hearth är ett exempel på den digitala utvecklingen som sker inom EU, där vi ser ett bra samarbete kring standardisering och harmonisering av olika datamängder och indikatorer för att bättre kunna bidra till goda förutsättningar för forskning. Hälsodata och digitaliseringsfrågor är högt prioriterade för den svenska regeringen och något som jag vet att socialministern som är ansvarig för det arbetar mycket intensivt med. Och vi ser att det är nödvändigt med en utveckling som stärker hälso- och sjukvårdens arbete med tillgänglighet. Som att arbeta för minskade vårdköer och vi ser också möjligheten till en mer personcentrerad hälso- och sjukvård genom en sammanhållen och tillgänglig vårdinformation över vårdgivargränser. Regeringens stora och övergripande fråga på det här området handlar om behovet av en nationell digital infrastruktur i vården. Idag saknas det, vilket bland annat innebär att hälsodata inte alltid följer med patienten i dennes kontakter med vården. Och regeringen och dess samarbetsparti har enats om att genomföra en enhetlig och gemensam digital infrastruktur för den svenska sjukvården. En sån infrastruktur ska förstås präglas av höga krav på säkerhet och värna skyddet för den personliga integriteten. Tanken är också att den ska både komplettera och ersätta de 21 regionernas befintliga infrastruktur. Men målet med den här reformen är att hälsodata blir tillgänglig i hela vårdkedjan för all vård oavsett huvudman. Och en annan viktig poäng är att skapa förutsättningar för en innovativ utveckling med patientsäkerhet i fokus. Det finns också kopplingar mellan regeringens ambitioner med en gemensam digital infrastruktur på hälso- och sjukvårdens område och EU-kommissionens förslag till ett europeiskt hälsodataområde, så kallat European Health Data Space. Där syftet ju är att dels ge enskilda inom EU en ökad kontroll över sin hälsodata, dels att göra det lättare att dela och få tillgång till olika typer av hälsodata, både inom vården och för forskning och innovation. Den här digitala utvecklingen är beroende av att vi jobbar tillsammans när det gäller standardisering av data, implementering av exempelvis standardiserade vårdförlopp och användningen av exempelvis kvalitetsregister. Så att spridningen och delningen av både hälsodata och forskningsresultat kan komma till nytta för fler, både i Sverige och i Europa. Jag hoppas att ni får en givande och lärorik eftermiddag med spännande samtal och erfarenhetsutbyten. Och jag hoppas naturligtvis att ett tillfälle som det här mynnar ut i samarbeten och nya idéer om hur vi tillsammans kan bidra till hanteringen av hjärt- och kärlsjukdomar genom bland annat tidig upptäckt, förbättrad prevention och förbättrad sjukvård och forskning.
Was Acko Ankarberg Johansson, Minister for Healthcare in Sweden. And as I said, we will immediately go on to John Ryan from the European Commission.
Dear ladies and gentlemen, unfortunately I could not be with you today in person, but I really was looking forward to recording this message to support your work and to say a few words on the activities of the European Commission related to cardiovascular health. We know that one of the main causes of death in the European Union remain cardiovascular disease. The burden is on our citizens individually as patients in terms of the disability that they suffer, the illness that they suffer as a result of cardiovascular events. But of course, the lack of function, in other words, they may suffer from different types of disability to their normal functions when they've had a cardiovascular event. They may, for example, be excluded from the workplace or be able to work in a limited way. And of course, there are the impacts on the care system in terms of the care that needs to be provided, the social care, the social support, but also the economic impact, which is very considerable when many member states are looking to find economies and to rationalize their health systems. So I think it's really important that we focus during our discussions on the element of prevention and early detection and better management of cardiovascular disease. And this will contribute to better public health in general, affecting our citizens, affecting our health systems, and also impacting on our economy. The other point I wanted to make is that in relation to cardiovascular health, we're often talking about multimorbidity, which means that in addition to suffering a cardiovascular event, patients are often confronted with other serious conditions in parallel. And that, of course, makes it more difficult for health systems to cope, and it makes it more difficult for the individuals themselves to cope with their health condition. So we have also to recognize that the burden of cardiovascular diseases across Europe is quite different depending on where you live. Your prevalence or your chance of surviving cardiovascular disease is notably different. So this is an element of inequalities which of course has its roots in various reasons, either the health profile of the individuals or the health system's performance, or there are many other factors which can affect these differences of outcome. And that's an important point which we should bear in mind when we're talking about cardiovascular disease, as well, of course, as the aspect of gender. And of course, we know that there are major gender gaps in relation to cardiovascular disease, which we also have to include in our consideration of how to, what policies should be put in place. In the area of prevention, for example, the topics of unhealthy diets, physical inactivity, smoking, and alcohol consumption can be major factors in influencing the onset of non-communicable diseases, including cardiovascular diseases. And these non-communicable diseases represent together about 80% of the disease burden in Europe. In order to try and influence this progression on non-communicable diseases or chronic diseases, the European Commission works within the framework of the Sustainable Development Goals and also of the World Health Organization targets. And in the context of cardiovascular health, we particularly focus on helping member states to identify and transfer best practices which could improve the situation of patients and health systems. For example, we have been financing a project to encourage physical activity on prescription In other words, as part of the medical treatment of disease, that GPs or health systems can be encouraged to financially support physical activity for patients. Another project which we are trying to support at the moment was a project originating in Italy on early prevention and screening for cardiovascular diseases, which has now been extended from Italy to a number of other interested member states. And we have a more general policy which is called Healthier Together, which is a document, policy document adopted in June of last year, which aims to make the link between the different health determinants which can affect people's health and to propose a number of actions. And there is, for example, a link, as we mentioned, between cardiovascular health and smoking, or cardiovascular health and nutrition. So these are things where, you know, by acting together on a number of these health determinants, you can affect the burden of non-communicable diseases more generally. So the document Healthier Together tries to look at the disease pathway in terms of developing better data, looking at early detection, prevention, and also looking at it from the point of view of patients, how to improve the quality of life of patients. And we use the EU for Health programme to identify and to support projects such as the one on cardiovascular screening or on physical activity on prescription. We use the financial instruments to support these types of best practice transfer. For example, in 2021, we allocated 7 million euros for the transfer and implementation of best practice of 2 joint actions between the member states dealing with diabetes, and the second looking at healthy lifestyles and obesity prevention. The EU Health Programme last year continued to support this process of best practice exchange with dedicated funding of 55 million euros. And there we identified diabetes again and cardiovascular disease as our targets. So we have also launched financial support for civil society and NGO groups, including health professionals, to support the work of the member states in implementing these best practices. And we will also be continuing this process in the coming years in the EU for Health programme in 23 and 24. Let me mention as well that the Commission has decided to implement a prevention package later in 2023. This will consist of 2 council recommendations, or pieces of soft law, if you like, which will look at smoke-free environments and vaccine-preventable cancers. And I think in particular the council recommendation on smoke-free environments might be of interest to the cardiovascular community. The Commission is anxious to identify ways of helping member states and patient groups and health professionals in the fight against non-communicable diseases, representing 80% of the disease burden in Europe. Given that we have an aging society, given the fact that we have restrictions on the capacity of our health systems, we have to do everything we can to prevent the onset of these diseases, to keep people healthy as long as possible, and to improve the performance of health systems in dealing with non-communicable diseases. And your event is really very relevant for this type of discussion, and I look forward to the outcome of your discussions so that we can integrate these elements into our work. Thank you again.
Thank you. We are grateful for the comments from the Swedish government and the Commission, and we have A short message from Birgit Berger. She is CEO at the European Hearth Network. And the European Heart Network is a Brussels-based alliance of foundations and associations dedicated to preventing cardiovascular diseases, supporting patients, of course, representing patients' interest and funding research throughout Europe. Please, Birgit.
Dear Minister, dear ladies and gentlemen, a warm welcome from the European Heart Network. We are a Brussels-based alliance of foundations and associations dedicated to fighting heart disease and stroke and representing patients' interests throughout Europe. Our vision is that every European has a right to a life free from avoidable cardiovascular disease. I'm very much honored and delighted to address an important topic, healthier hearts, why boosting cardiovascular health policy is critical for Europe. Because we have a very heavy burden to address. If CVD were a country, the capitals would be heart disease and stroke. The economy, 210 billion per year. Population, 63 million. So that's the size of the patient population. Mortality, 1.8 million per year. Population growth, 6 million per year. Productivity loss, 26 million years lost to ill health and early death. So a European cardiovascular health plan, why? Because it represents an opportunity to reduce premature and preventable deaths, tackle inequalities, pave the way to better quality of life and healthier lives for all. It also would create resilient healthcare systems. How would a European cardiovascular health plan look like? In our views, there are 4 pillars: primary and secondary prevention. So we need ambitious public health measures to mitigate cardiovascular risk factors. There is the importance of early detection and secondary prevention. We foresee a second pillar, which consists of digital technologies for cardiovascular health. We believe digitalization can create cardiovascular innovation. Also, this innovation is helpful for saving lives. The third pillar looks into modernizing cardiovascular patients' pathway. In our view, interdisciplinary healthcare models are the way forward. Also, the digital technologies just mentioned would help to strengthen outpatient care. The fourth pillar, last but not least, means we would like to improve health and digital literacy to tackle inequalities. So, a European cardiovascular health plan, we are convinced, is needed in order to reach these goals. As Benjamin Franklin already said, if you fail to plan, you're planning to fail. In order to be successful in cardiovascular health, we are looking very much forward to working with all stakeholders under the Swedish Presidency for a European cardiovascular health plan. Thank you very much for your attention, and I wish you a very fruitful meeting. Thank you and goodbye.
And thank you, Birgit Berger, for your input. Now we will go live from this room. The last speaker in this episode is Thomas Magnusson. He is chairman of Diabetes Sweden, an organization that represents, as you understand, patients in Sweden. Please, Thomas, the floor is yours. Take this one if you want, please.
Thank you very much to be invited here. I have to put the oculus here. Who is Thomas? Thomas is 67 years. I have type 2 diabetes and I have a cardiovascular disease. And what I'm trying to say that I have different diseases and I'm not just one disease. I think this is very important. As a patient representative, what will I say to you? First of all, I would like to say, speak with us. not only about us. I think this is very important, that many of my members and people I meet saying that they feeling that the healthcare is not speaking to me. They don't understand. They don't really can follow how to do, what to do. Of course, one of the main problems is that we are individuals. We are different. We are different as a person, and that means that is a kind of a challenge for the healthcare to try to explain what to do to the patient. You can say something to one man, but to the next patient you have to say in another way, in another type of instruction. But it's also interesting to know that as a patient, I have different kind of education. I have different kind of knowledge. And I used to say that I feel I'm a bit normal talent. I can understand a lot of things, but I don't have any medical education at all. I've never been interested to learn something more about that. Of course, I have some knowledge about me in my life. I'm not 20 anymore. I'm a bit older. I've been learning during the years how to do, how to feel, and what can I do to feel better. I will give you an example. I met a nurse some years ago, and she said to me, think that you are responsible for your treatment of your diabetes. And I was a bit surprised why she said so. I was trying to joke with her, and I said, what do you think I come to you for? I come to you because you have to help me. And she said, of course, I will help you with everything I can, but you are responsible. But I said to her, okay, I understand, but then you must help me to take this responsibility because I don't know what to do. And then we're still discussing this after many years, what to say, what to do. But I think this is very important because we have so many days, so many hours during the year. It doesn't matter what kind of disease you have, but you have to take your self-care of you have to do what to do, how to treat it. And then you need the tools to using that. You need to understand what to know. Not only that someone is giving the papers that you go to the pharmacy, you will buy these medicines and so on, but you need a lot of tools to using all this possibility that you really have. And then we can go back, what is a normal patient? Is he or she interested to handle himself? And I will say yes. But then we have different possibilities, we have different opportunities to do it, but the healthcare must be there and helping us to take this responsibility. One of the problems we have the down spots, what we can say. I can feel that my doctor was speaking diabetes in one day. My heart doctor is saying something else. My heart doctor said something so that, well, your doctor in diabetes have wrong right now. Not normally, but yeah, for the moment now. And we can feel this, that they are so different. Everyone is working in his way or her way, but they are not looking at me because I have to live with the different diseases as I have. I think there's another thing is important, early detection. What we have a discussion in Sweden many times that we have complications will come in and the cost for the society is rising and rising. And I, as a patient representative, think it's very important to discuss that about how can we do, who can we start earlier, who can we help people early, who can we work that these complications do not exist, not starting. But from my point of view, it is another thing is more important. It's the quality of life for the individual person. This is much more important. This is the reason why I think early detection is so important for the individual. But maybe we could make it like a win-win situation, that we can talk about the quality of life, but we can also talk about how we can be more careful about the money which we're really using for that. This is one very important thing, I think. And then we also need to say new treatments must become much more quickly. Sometimes you can look out in Europe and see there's something happening in other countries in Europe, but why not here in Sweden? Sometimes we can feel that we have it in a national level. But when I speak with a member living in a small town in the countryside in Sweden, okay, oh, that's interesting, Thomas. But when I come to my nurse or to the healthcare next time, do they know what we are talking about? We have a lot of challenge to work with that. What we have in Sweden, as the minister was talking about, the quality registers, and I think this is very important that we're using them, and we also trying to use them daily to have the how to say, that is very important to fulfill the register and to using what are we learning from them. It could be saying much more things about the patient representative's voice. I'm very glad to be here. As I said in the beginning, don't only talk about us, talk with us, as we're doing here, because we are going to a journey to get better treatment. And on this journey, we want to be joined together with the healthcare. Because I want to live a better life, but I need the healthcare to show me how it could be and what I have to do, and in different way. It could be physical activities, it could be what I am eating, it could be what kind of medicines I'm using, but all this together will give me these tools so I can handle my daily treatment. Okay, thank you very much.
Thank you, Thomas, and thank you for focusing on the patient's experience, which is what really matters, of course. Thank you very much, and that was the last intervention during this episode. I will now pass the floor to Mr. Petter Odmark, Head of Analysis and Health Policy at Reform Society. Please, Petter.
Yes, and now we'll switch to talking about something that especially the minister put a lot of emphasis on, utilizing health data and quality registries. And the registries has already been mentioned by most speakers, I think. So I would first of all like to invite Peter Vasko and Fredrik Söder to join me up here. And hopefully I will also have David Love and Hanna Svensson on the screen. Yes, there you are. So, welcome all of you. The subject we are going to discuss is utilizing health data and registries to improve cardiovascular health. And I think it was really important that Acko Ankarberg put such a big emphasis on this. And of course, I suppose we will talk about it kind of as a tool and in theory, perhaps to some extent. But also I think what John Ryan was emphasizing, two things, prevention and early detection. I'm quite sure we will touch upon how to actually use these tools to achieve those goals, since that's, of course, is the key objective for us. So, but first I introduce my brilliant panelists. So, of course, the star guests on the screen. First of all, David Love. You are the Clinical Director of the Scottish Health Innovation Partnership and also Emergency Consultant at Queen Elizabeth University Hospital. Welcome so much, David. And next to you, not maybe physically, since you are in different countries, Hanna Svensson. You are a researcher at RISE, Swedish Institutes, as actually a plural there, Institutes of Sweden. You are a specialist, among other things I know, in the use of self-collected health data and self-monitoring. And you're also an expert in your private life, since you have been self-monitoring your diabetes your whole life. So I know you have a lot of both professional and personal thoughts and experiences on this. And with me, I have Fredrik Söder. You are the CEO and founder of the company Health Integrator. And I was thinking, Thomas, when you talked about the conversation with the nurse, actually, yeah, I can take responsibility, but I need the tools. I think that's really down your alley, Fredrik, supplying the tools for taking responsibility. Yeah. And last but not least, Peter Vasko, something as creative here today as a cardiologist. But also chairman of the Swedish quality registry, Swedeheart. And I suspect, Peter, that when the minister told us he was proud of these Swedish experts working in Europe in creating Euroheart, you were one of the persons she was proud of. So we are proud to have you here. I would kick this off, and want to give all of you the opportunity to just describe for the rest of us, in your everyday work, how do you use health data and registries to improve cardiovascular health? And I also asked you to expand a little bit, looking forward, what do you see as the key things that we need to focus on or improve going forward in this field? And I would like to start with David. And I know, I've done my research, that you have really exciting things to talk about when it comes to early diagnosis and using new tools to improve, especially within the field of heart failure, but I'm sure you have other stories also. The floor is yours, David.
Thank you very much, and thank you very much for the invitation to speak today. So as I said, I'm David Lowe. I'm a pleasure being the Clinical Director for Health Innovation within the Scottish Government, but here really to present a programme of work focused on transforming heart failure care as the clinical lead for the west of Scotland. We essentially look after 1.2 million patients within Greater Glasgow and Clyde, and anybody that's had the pleasure of visiting Scotland will know that we have fairly significant challenges in our comorbid ageing population, and how do we deliver care given the high prevalence of especially cardiovascular disease. We do, however, in Scotland have the opportunity to co-design and co-develop and critically co-evaluate innovative technologies to provide clinical and market validation for adopting these. I think it's really important to state, first, that this is a collaboration across specialties and disciplines, and I think we've heard a little bit about that already today, about the importance of really being able to bring that together, because there's experts across these fields that need to be brought to bear, and in this case, support from AstraZeneca, Roche, Linus and US2I as industry partners. As has already been said, we've in Scotland looked with some admiration at SwedeHeart from its inception, and we've identified really the critical need for us in Scotland to respond to that and create registries across the cardiometabolic and renal axis that can be leveraged to drive forward clinical care, to reduce variation, enhance workflow, and really to provide provision of data to support clinical research. So OPPA is really in response to that, and it was a piece of work that I'm going to present today, which is around an optimised pathway for early identification of heart failure, and is really a vanguard of our approach to manage long-term conditions, and was designed in response to really the significant challenges we're experiencing around about heart failure diagnostic backlogs, both in Scotland, in the UK, but worldwide, and again, that ageing, increasingly multi-morbid population that really require solutions that improve the productivity and efficiency for the workforce within that healthcare system. We know, and has been discussed today, there's a lack of heart failure awareness, early detection is critical, and timely access to diagnostics and specialist care is crucial to improve outcomes. And therefore, what we did was really meaningfully look at those critical steps and systematically respond to them. And what we did was create a digital diagnostic pathway that was in response to this. Standardised referral, including vital signs and a BNP, a biomarker to detect heart failure, active clinical referral and triage, a comprehensive review of that diagnostic request, allowing us to be able to assign patients the appropriate pathway, and a one-stop diagnostic clinic, including Acko, and we'll get onto the AI components of that, as well as nurse consultation and therapy initiation, if appropriate, at the time of their presentation. And crucially, that's one presentation. That's not coming to hospital for an echo, then to a nurse consultation to collect your weights and a blood test, but one-stop clinic. And finally, a virtual consultant review based upon that structured data to set out a treatment plan and follow-up to ensure that etiology is defined. Briefly, and I think as has been described for Swedeheart, the platform enables granular data collection at the point of referral, aggregating lab data, diagnostic data prior to, during the clinical visit, and critically linking to follow-on data, and providing structured data collection against symptoms, patient-reported outcomes, as well as treatment initiation, being able to follow their therapies through. In the future, this will allow us to really optimise patient support by creating a platform for both trial delivery as well as support key actions such as therapy optimisation. Data is clearly critical. Within Scotland, we have the advantage of a national personal identifier that allows aggregation of electronic healthcare data, both in primary and secondary care, including lab results, imaging, and increasingly a focus on development of a health data exchange to be able to pull through patient-reported outcomes and wearable data. So during and pre-COVID, we had a significant problem around about backlogs. We had essentially a 12-month waiting list within Greater Glasgow and Clyde for the diagnostic pathway. So we designed both this digital pathway, but equally validation of AI Acko to streamline the provision of care, and brought 900 people through this pathway in a Nightingale hospital that was set up in the midst of COVID. This is really critical to both reduce unplanned admissions into hospital, where my emergency department is particularly challenged, but also to make sure that backlog was responded to, because we know that that's about equity of access to care. And we, through the time for that 12-month backlog, we were able to get that down to 6 weeks and maintain that. The pathway, unsurprising for those in the room, was able to describe a management plan with 68% of those people receiving a new diagnosis, with a third of those having reduced ejection fraction heart failure, and a further 2/3 preserved ejection fraction heart failure, but also a number of other cardiac findings such as angina, amyloid, and AF, and other diagnoses such as renal disease and COPD. And that management plan allowed us to provision and drive on care for those individuals. The pathway is currently undergoing scaled adoption across a number of health boards in Scotland, with an aim to create a unified approach to both the heart failure detection, diagnosis, and management. And there's really a manifestation of the triple helix approach of close working with healthcare systems, the NHS, industry, and academia, as really an example of how close shared working can deliver transformative change that responds to patient partner priorities, and from a clinical and technical level, how we can reduce fragmentation of delivery, which you just heard from the last speaker. Firstly, that patient experience must be improved to improve engagement around about coming to clinics, taking their therapies, but also for patients, and how can we integrate and implement solutions that recognise that importance, as well as has been described, a multimorbid population that often have multiple conditions that we need to respond to. So the primary outcome of this piece of work was to validate AI image interpretation to improve efficiency of echo reporting. Certainly within Scotland, access to sonography is a critical step, and how can we improve that? So we've got a fixed workforce that we're trying to train more of, but if we provide AI provisioning that supports reporting, we can reduce that 30-minute AI acquisition of echo down to potentially 10 minutes, allowing us to do many more echoes during that time. In Glasgow, one of the largest health boards, we had those significant backlogs, which again was multifaceted, with a driver of 80% of patients were getting a diagnosis of heart failure during an index hospitalisation, arriving at my emergency department, associated with increased length of stay, cost, and mortality at 5 years being up to 50%. We know that diagnosis in the community is possible, and 50% of people with symptoms for up to 5 years prior to getting their diagnosis, with a twofold increase in mortality at 1 year if this diagnosis is made in hospital rather than the community. And this is data from Scotland, but clearly has resonance across the world. So AI interpretation, and ideally creating an evidence base to utilise AI Acko as both a screening and diagnostic tool, will support early detection of heart failure and allow us to move into community diagnostics hubs or even primary care. A critical part of this is the health economics and evidence generation to support decision-making around about adoption. We are all living increasingly fiscal restrained times, and what we're able to demonstrate with academic health economic colleagues is approximately a 4K incremental cost efficiency ratio, which is highly cost effective and enables guideline-directed therapy to be provided. In Scotland, across the innovation landscape, we're really driving through the need to be able to not just demonstrate clinical and cost effectiveness, but also acceptability of both for the patient and staff to engage in these transformative diagnostic pathways, because they are challenging to the workforce, and we know that they're kind of well wedded to their current solutions. And technical performance, especially within the context of AI, is critical. Yeah. And this is really to support decision makers at board and government level to prioritise investments, recognising heart failure is a huge problem, and how do we provide solutions that are meaningful and actually deal with both backlog, but also ongoing care requirements for those individuals. Yeah. And this work is really created a provocation of how we can efficiently develop clinical pathways to support equitable, timely access of care. Our Chief Medical Officer for Scotland has really asked us to focus on demonstrating sustainability with carbon and cost, as well as workforce responding to inequalities. And this programme has delivered this. And that's really critical, being able to demonstrate triple helix working, industry, academia, and NHS working together, delivering registries that support this, and we're moving forward into, and we already have a very well-established one in diabetes, but then how we can use those registries in diabetes and heart failure to identify those at greatest risk, and we're doing that through a programme called Symphony and Tartan within Glasgow, and that is a worldwide trial. The importance of AI is critical, but has to be targeted, and AI is about enhancing reporting and potentially access of Acko in that context, but also using structured data from registries to enable case finding, identify who's at highest risk in the population, using time series analysis, which is my area of academic interest, and then prioritisation of heart failure detection at a population-based level. Creation of those high-value data sets allows diagnosis to be made, long-term management and escalating care requirements to allow proactive interventions to start to move our model away from time reactive care delivery models that are really predicated on patients arriving in the emergency department.
Thank you, David.
An ambulance and having poor outcomes. So thank you very much, and very much look forward to hearing from the rest of the panelists.
Yeah, thank you so much, David. I think it's a really impressive project. Actually, the thing that I just quickly want to ask you, what I might find most impressive is that you are actually in the scaling up business of getting it out of the project and into the rest of NHS Scotland. Could you say just very shortly, what's the key? Because that's where we often fail. We build impressive collaboration around specific projects, but the scaling up and making it work in other places are often lacking. What were your one key thing about scaling this up and making it spread in Scotland?
Yeah, so I think the first thing is understanding the confluence of demand and need and prioritisation for decision makers and government, which is ultimately about unscheduled care demand and equity of access, especially in long-term conditions. It is about drawing a team together to be able to demonstrate the value and impact of transforming care, and it's really about developing evidence, and that's why it's really important to work again with industry, academia, and the NHS to really be able to evidence not just that this project is great, it can work in isolation as really motivated academics, but how can it be scaled and adopted and respond to working clinicians that don't potentially have ivory tower university behind all those resources. Pragmatically, how can it go into a health board without those resources? And that's really about stakeholders and bringing them together early to understand what their drivers for adoption are. Thank you.
Thank you so much. Hannah, I'm giving the floor to you from the beautiful city of Gothenburg.
Thank you. So I will tell you a little bit about what we are working with on RISE in order to support the use of health data to decrease the risk of further cardiovascular diseases. So RISE is a quite big research institute consisting of several research institutes. We are more than 3,000 persons. So what I'm talking about today we do much more than what I will mention here. But we work with supporting industry, academia, and the public sector to ensure competitiveness of Swedish businesses, but also to contribute to a sustainable society. And the work we are doing within this area is general, and we like to have the individual in focus. And why we have the individual in focus and not the disease or the healthcare system is that the risk to develop a heart disease, that that is affected by our lifestyle habits, but those habits are also affecting other kind of risks to develop other non-communicable diseases. So focusing on the individual, we will decrease the risk of all the communicable diseases. So the focus is on supporting individuals having good lifestyles. And that comes all the way from how we build a society with roads and streets and so on, to how we design a good healthcare system. So we are a bit broader than many others. And another reason why we want to support the individual is that when the individual uses his or her own data in order to learn and gain knowledge about their health to be healthier, they will also use knowledge that are not captured in the data, such as quality of life, nutrition, and so on. So when the analysis, or which sometimes are AI-based, is done on the individual level, we can ensure that it's easier to reach high quality of life, which Thomas spoke about earlier. And the further away we come from this source, we will know less about measurement uncertainty and less about what's important to the patients. And this uncaptured information is lost. Another thing that we have noticed when we are putting the individual in focus is that the interpretation of what we mean with health data is different when it comes to patients, organizations, individuals, and compared to the healthcare sector. And of course, when we have this mismatch in interpretation, we will talk about things like sharing health data with different goals. So as Petter said in the beginning, I live with diabetes type 1 since more than 30 years now. And diabetes is a very measurable disease. So I think that gives a good glimpse into the future of other diseases and how to live with those non-communicable diseases. I've done an investigation that showed that much less than 1% of my measured health data, and then I mean glucose levels, laboratory measurements, records in the journal, and so on, much less than 1% of that was data captured in healthcare. So if we want to make a good use of health data to promote health, we need to look at the individual level and see what's important there. More specific, more than working with measurements done by the individual, we also work with measurement scales for symptoms and experience in order to capture latent variables such as quality of life or physical ability and so on. And we also works with comparability and traceability of measurements. And this is really important when we are starting to collect more and more data and comparing and doing AI and analysis on it. Because if we are just comparing or using data as mere numbers, we will draw a lot of wrong conclusions. For example, some of you might have an activity tracker or an exercise tracker, which gives you a measurement or a number on your stress level. And for most people, this it gives you some understanding of your stress, but the number could vary a lot, even if you don't think that your own estimation of your stress level varies. So that is not a comparable measure and shouldn't be used in big AI analysis. When it comes to infrastructure, we work a little bit with the infrastructure for data or health data. We are participating in government assignments and answering remittance and so on. And in this work, we are trying to move from a triple helix to quadruple helix context and incorporating individuals, patients, organizations, and so on. And also, yeah.
I was thinking, Hanna, one of the things that you mentioned, I often think about that in the policy space, like we are today in some sense, we often phrase it health data and then we kind of automatically go to healthcare generated data. But your point is that we have so much other health data, and somehow it's also the dialogue between healthcare and patient, individual. How do we match and mix this? From a policy perspective, how do we bridge the gap, the understanding of these different kinds of data and make them work together? Do you have any suggestions for?
I think that we first need to have a better and more common interpretation of this legal framework. And the first step is to acknowledge that there's a misunderstanding and this gray field where we don't know how to interpret the framework. For example, is self-monitoring data that comes from sensor that the healthcare pays for, is that something that goes under patient data law, or is that something that goes strictly under GDPR? And I would say that's still no good answers on that.
I do have a answer there, so
yeah, but actually, maybe we give the bridge because Fredrik, you and Hanna have different, well, kind of similar takes on this, but also come from a slightly different point of view. So please.
Just answer Hanna's question here. From my perspective, I think innovation is very much about you don't have all the answers from a data perspective when you start. So you need to start somewhere, do something to create the data, and then you can step by step improve it. Sometimes we're seeking all the answers and need all the answers before even get started, and I think that's the major problem here. And I think that's very important to highlight in this perspective.
Yeah, and maybe we can switch over to your story, and since that's a lot about enabling the use of personnel and also not only data but also the quality of life and how I learn about myself. So
and we are Health Integrator. We are a service integrator of existing services, product, service provider within preventive health. So we don't invent anything new, but combine and integrate that. And that's a new perspective into this, combining this instead of just inventing new things all the time. By doing that, we can also measure the outcome of what we actually create for the group or population that we're working with, but that also enable new ways of financing prevention, which is, I would say, the Gordian knot of prevention, the financing part. So the first case we're doing are here in region of Stockholm, where we find David working more from a clinical perspective. We are so one step ahead here. So can we find individuals at risk before they even are patients out in the society? So what we have started with is, can we find individuals of risk of type 2 diabetes within the society? 50 to 60-year-old was the target group. There are 316,000 of those individuals here in Stockholm. 29,500 of those have signed up and done a self-assessment of risk of metabolic disease, which is close to 10% of the total population. 15,000 of them then took a long-term glucose test, HB1AC. 10% of them were in the risk zone of type 2 diabetes. Plus, we found a few hundred individuals that actually had type 2 diabetes who can get really, really early detection before we even know they were patients. So that's showing as an example. I mean, we are example, bring this into action, what we actually can do. So that is the first step, early detection. Secondly, we create a data profile around each and every user. Talking about data is good, but it's useless until you turn it into insight and knowledge for the individual, because otherwise you can't use it. So that we do in the next step, where you have a digital health coach that have 3 years university training in behavioral change, not a nurse, not a physician, not a doctor, but behavioral change. Back to Thomas here. They help and guide the individual making informed decision around the health, and building up insight and knowledge around the data set we just created. Each and every individual will get a personalized plan and goals, what to do. Brilliant. I know what to do, how to make it happen, it's personalized. But how to bring action out of that? And that's where we normally create a new solution, a new app, and say, one size fits all, let's push that out and see how it works. What we have done differently as an integrator is that say, hey, there are a number of good services, product service providers within physical activity, nutrition, stress, sleep, alcohol, tobacco. If we provide that as a toolbox, and we have like 130 different services and products on what we call a marketplace today, where the individual then get guidance from the coach and find the right tool set for reaching my personalized goal and plan. So everything is personalized, but we're reusing what's exist, and as a broker bring the need with the supply of a market. Then we monitor the individuals that they get continuous coaching, etc. And then we can continue to see the outcome of this population. So now we have 18 months data, and 45% of users are out of the risk zone of type 2 diabetes after 18 months. We keep the users. 8 out of 10 experience a better mental health. They lost 3.5 kilos, etc., etc. So we have a full data set and can monitor this population and the outcome of that. That is great, but then we come to the next challenge, how to pay for this, and that's where it normally stops. So what we have done for the first time is also help the payer, in this case Region of Stockholm, to bridge financing the gap between investing in preventive services and when you see the outcome, because that's normally a span of time. And that's normally something they can't bridge from a financial perspective because they work with budget and cost. And if you will find an investment in a budget, it needs political decision and so on. That probably never will happen. So we have issued the first health impact bond together with financial institutions here in Scandinavia, which is SEB and Scandia we're working together with. So this means that the region just pay for the outcome when it comes, which is a new way of seeing prevention, but also help the payer to finance and actually make this happen. So the result of this is that, and this is calculated by region, that the numbers we have now and what we can show if this actually works in the pilot, that means that we can give back to the region 2,400 new nurses every year. That's 140 million euro per year we can just save if we're scaling up in Region of Stockholm. That's equivalent to giving a raise in salary 10% of all the nurses, for example. So now the question is if the politician would like to receive this gift from us, what we're doing. So that's where we're talking about scaling up.
Yeah, and do that. I was thinking about the question I put to David about scaling up this project and making them work in other places for a larger number of people. And you and I changed a few words about that. From your point of view, what is the key factors? Are we capable of adopting these new models, and how do we get them to grow into other areas or other regions in Sweden or so? Because I think there is a lot of work going into establishing it. What are the key levers?
Political leadership and courage.
Yeah. Simple.
We check on all. I mean, it works. We have the financing. Everything is solved. So why are we not doing this? It takes action. We're talking about the problem. Why not doing?
Great. And from these projects and rather individual focus on strengthening my own capacity to improve my health, over to the more systematic, maybe, Peter, approach to aggregating large amounts of data in registries, and what can we learn and systematically improve quality? Give us a short view of it.
Okay. But first of all, I want to be like Thomas and Hannah too. I want to be an individual. I want to decide my strategies for life. Even if you are poor and marginalized, we have to decide what to do each day. We have to make choices. For healthier hearts, a great part of diseases depends on lifestyle and our habits. I think it's always important to have it in focus when you meet such big social ministers and so on. It's the individual responsibility is the greatest. And I just want to put one thing for you. One of the main reasons for later stroke, atrial fibrillation, heart failure and kidney disease is high blood pressure. Check your blood pressure each year from that you're 18 years old. What do you have for blood pressure? I have 118/66 the day before yesterday. It's good for me, I think, and it's even good for my wife. Blink, blink. So we can, of course, do what we want with our lives. What can we do as organizations? We can use evidence-based medicine, of course, but that's not enough today. We have to do it cost effectively too. Evidence, of course, it's the God. But if we could do it cost effective, we could deliver more evidence to more people. So we should give a care that is value-based, not volume-based. And of course, Hannah and Thomas, empower people in the prevention and care of diseases. That's the individual part. Then we're talking about what I like mostly. I like to collect and compare data and change the clinical care in Sweden towards enhancement and development of evidence-based care in heart disease evaluated according to recommended therapies. That happens to be the text behind the abbreviation for Swedeheart. And we like to make cheap studies in a smart IKEA way. Registry-based randomized clinical trials, 10th as cheap as the old ones. We want to change the world, how the world acts in treating heart disease. So first, collecting data. We are professionals and have in our communities made registers that are nationwide and harmonized. And now I will make the fingers for the 21 regional authorities in Sweden because they have been extremely passive and counterproductive in harmonizing and collecting data. Is someone from SKR here today? Listen to me and talk to me of this. Swedish Association of Local Authorities and Regions hasn't the authority and drive to harmonize their members. But we did. Swedeheart changed the way Swedish hospitals treated acute myocardial infarction through collecting and comparing on a professional initiative. I want to say the Swedish government, I was needing something for the tears. Because Acko talked about this so much. I have never heard someone that talks so much about it. I was really moved. But that's the government, that's not the SKR, the Swedish Association of Local Authorities. And we want to collect and compare, and we did in Sweden, of course, between hospitals, but even between countries. There is a very famous comparison between UK, 390,000 patients, and in Sweden, 120,000 patients compared. And we found clinically important differences, such as use of PCI and diverging lines in mortality. And while we could compare with UK, was that we thought that we could have harmonized data sets so we could compare it. Next, I mentioned RCT, register-based randomized clinical trials, a world invention. Forbes, an economic magazine, described it as a disruptive taste of the future. It was about the first RCT ever done, the TASTE study. The TASTE study tested in a randomized setting thrombus aspiration for ST segment elevation, STEMI, if it was good or not. The United States has already implemented guidelines about doing this procedure. But the small country that included every patient under 1 year said that it was not effective to do that. And the world, even United States, changed their guidelines. A less dramatic study was Detox, a study where you tried if you should give oxygen to every patient with myocardial infarction. We have done that for 30 years with no evidence, but we thought, it could be good. We didn't know if it was dangerous or not, but we wanted to test it. No one wants to pay such a study, but we did a study, Detox, cheap and fast, and we changed the all words guidelines in myocardial infarction. We don't need to give oxygen for every patient with heart failure. Now, what happens now? The next vision is to repeat the Swedish success on a European level, Euroheart, as Acko also mentioned. First thing, harmonizing variables, standardized data settings, and 3 levels of variables. Level 1, mandatory, level 2, additional, and level 3, country and center specific, perhaps some legal things. And the first collection of data will be published in August and presented at the European Society of Cardiology in Barcelona. And it will be the first time.
Peter, I also have a question from the audience, but first, really quick. Euroheart, is that still more of a professional collaboration, or have you mobilized also other politicians to driving this?
We have got money from ESC, and the money to ESC mainly comes from the industry and from members.
Yeah.
But no, we haven't mobilized.
Because I think this is really interesting. But Emma, you have a question from the audience.
Yes, thank you. I have a question from our digital audience. And in summary, it is, do you think that the taxpayers will accept the cost of new medicines and innovations?
Who wants to answer? It's a simple question, friends. Peter.
Sweden has a formal way for that question, and it is Socialstyrelsens riktlinjer, guidelines, and they make a sheet of evidence, how important it is for the people, for the patient, how much it will cost. And then you have a number of it from 1 to 10. No one else does it like that in Europe. So you could always measure what is important and what you want to pay for it.
And you had another one, Emma?
There's also 2 questions for Fredrik, and it's about Health Integrator. Who are stopping you is the first question. Yep. And the other one is, how are you attracting investors to your health impact bond? A lot of uncertainty, and the investment until improved patient outcomes starts to deliver returns.
And good questions. And venture capital or pension fund are, taking risk every day. It's risk return. That's what's a pension fund. We take care of a pension money, so to say. So here we see a huge value in what we're doing and how that can create value, and then taking risk and return based on that. So in finance, that's always balanced. So if you take a risk on board, how much return to get to take that risk on board? So it's self-regulating in this structure. The interest from pension fund, and which is the structural capital here, is huge because they need to invest sustainable. And this is probably one of the most sustainable investment they can ever do. So they are a huge interest from capital market around this.
Yes. Emma, do you have one more?
Yeah, and that is for the doctor. That would be you, I think. Do you support or try to stop health integrators?
I don't have the decision underlag for that.
You're supporting.
I'm
Just say
interesting,
supporting.
and he looks so enthusiastic. So it's I can't answer that.
I will leave this panel in the warm hands of Martin just in a minute, but quick. Peter has already given call out to the Swedish regions on what they should and maybe should do or not. The rest of you, do you have one policy lever? It could be the Scottish government, the Swedish, some other government, or the European Union that we really need. They need to pull that lever now to speed things up. So I start with... Yeah, okay, Fredrik. You are so eager, so I go to you. Yeah?
No, I think it's back. Stop talking, start doing. Very simple.
Hanna.
So talk more with patients and individuals in order to broaden the scope for health data.
Thank you. And starting and also then finishing, David.
Thank you. So I think it's about demonstrating value and understanding what stakeholders need for evidence to allow them to make that decision to fund, support and deliver. So I think stakeholder engagement and developing the evidence to respond to their needs to allow them to make the right, brackets, the good decision.
So if we do our job, they will just follow. That sounds good. So thank you so much for joining this panel, and thank you for all the insights and interesting reflections on health data and registries. Now I leave the floor.
Perfect. Thank you very much. My name is Martin Stegmo. I'm the medical director for Berger in Sweden, but I stand here as a representative of all the life science companies that are participating here today. That is Amgen, AstraZeneca, Bayer, Novartis, Novo Nordisk, as well as the Swedish and European Pharmaceutical Industry Society. But furthermore, I also stand here as I have been a clinical cardiologist for over 20 years. So this is a really, really important topic for me. I have been very interested, both clinically and research-wise, in prevention of cardiac disease. So it's a great honor for me to be here. We are talking this in the context of the Swedish Presidency of the European Union. And we have to realize, in our great European Union, we have so much knowledge, so many ideas. And this knowledge comes from everybody. It comes from the healthcare profession, from researchers, from patient organizations, from taxpayers, and also from decision makers. So why not use all this combined knowledge to do something good together? And the topic of this session is actually to share best practice over Europe on examples of national policies for healthier health. And I think the idea should be here to steal with pride. We will go across a very, very esteemed panel here from all over Europe. I feel almost a little bit like the Eurovision Song Contest here, where we are going to different countries. But we will get perspectives, ideas, success stories and failures from different parts of Europe. We will have about a 7 or 8 minute presentation from different countries. When you hear me coughing, that means your time is up. And then we will have a discussion in the end. And I hope we should all learn from this, because we all want to join here. First of all, we go to, I think we go to Madrid, to Professor Hector Bueno, who is the Vice President of the Spanish Society of Cardiology, but you're also the advisor to the Spanish Ministry of Health and their scientific coordinator for their national strategy for healthier hearts. The floor is yours, Professor Bueno.
Good afternoon. So, well, I think we are privileged to have probably one of the first national plans on cardiovascular health. That's a very important, I think, step, as actually despite the fact that cardiovascular disease is the #1 killer all over Europe, actually in the world, there's very few countries in which there's a cardiovascular disease program, or even less cardiovascular health national program. And that's what we have recently presented in Spain. First of all, we were lucky because, I mean, it was the Ministry of Health who had the initiative to bring this forward. They asked me to try to think how to have a strategy on cardiovascular diseases. I said, probably you're running short, and probably we should speak about cardiovascular health rather than disease, and look very much to the population, education, and so on. And they were very receptive, so they bought the idea. So we were lucky again to have the ministry, let's say, receptive to our messages. And we gathered a large multi-professional group with more than 100 persons, including healthcare professionals, non-healthcare professionals, also patients, representatives of other ministries and other perspectives. We had a vision on how to see from a multidisciplinary standpoint what was needed in Spain to improve cardiovascular health at a national country from the patient perspective. So actually we did some moves. We moved from cardiovascular disease to cardiovascular health. We moved from the healthcare system to the society, from patients to patients and citizens, and from professionals to all players involved. So we developed a plan which was actually an integrated view on what was cardiovascular death in the population. And for that, there is the need to have the perception of what are the determinants of health and also the determinants of inequality. That's very important because, for instance, Spain has a decentralized system, which is actually the case for many countries in Europe. And actually, the ministry itself has a very short power to decide because the provision of health, the delivery is given by the regional departments. So they had to be agreed with all the regional systems, but we managed to do it with this vision. And we then focused on health promotion, cardiovascular prevention, early diagnosis, and then getting into the healthcare system through primary care, hospital care, and social care after the acute care for chronic patients. So we actually get a view from the initial, the subclinical state of the disease, that is from childhood to the end of life. And then we consider what were all the players needed to go through all the course of health and the loss of health, and that is cardiovascular disease. And we also consider the issues needed for keeping the equity, let's say, in terms of regional inequalities, but also some others which are very important and they are particularly relevant for cardiovascular disease, like social, economical, gender issues, which are very important. With that, what we created is 3 overarching lines, which was continuity of care, patient safety, and data. And I think I was very interested in the previous roundtable, in which using information and accurate information and data to leverage the change, I think is absolutely essential. We consider this as one of the 3 overarching lines. And then we designed 6 transversal lines, which was health promotion, prevention and early detection, citizen empowerment and participation, knowledge management, research, development and innovation, equity, and comprehensive care for persons with acute and with chronic disease, which actually crossed with the four lines that we consider longitudinal, which were among all cardiovascular diseases, we selected ischemic heart disease, heart failure, arrhythmias, or sudden death, and heart valve disease as those with the highest impact in the society. So we created a matrix with these transversal and longitudinal lines in which the team actually draw a heat map of all the priorities needed to improve in Spain as top priorities. And then we designed a strategy in which actually there was these scopes of action, these particular lines. From these, we selected 27 out of the nearly 100 critical points that were selected. So we selected 27 out of them. From these, we selected 99 strategic aims, 134 actions. And of course, we wanted the strategy to be able to be followed up and developed. So we decided that we needed indicators to track the strategic action was developed during the next years. So we have 61 indicators, and we have a design on a strategic market scorecards to follow them up. So in fact, next Thursday will be the first meeting with the ministry and all the representatives of the regional healthcare systems to decide what will be the shorter plan for this year in terms of deciding all these 134 actions, which ones will be prioritized to start with, as we have a lot of work with this plan. So, I mean, grossly, this is more or less what we've done in Spain. And I think that, in fact, we really need something similar for Europe. We have actually a cancer plan in Europe, which is great, but cardiovascular disease remains the first killer in Europe, and we need kind of this project and plan in Europe, actually tackling the inequalities that occur. And we know that we have these gradients in Europe in cardiovascular diseases. And I'm talking about epidemiology, I'm talking about the society, risk factors, I'm talking about primary care, I'm talking about quality of care in hospital, I'm talking about chronic patients as well. And all these sources of inequities that are also related to social, economic, cultural issues that need to be tackled. It is not about cardiologists, it's not even only about healthcare professionals, it's a social endeavor to improve cardiovascular health in our countries and in Europe.
Thank you. That was really, really interesting and inspiring. I have one very short question to you. As this is, as you said, the problem of a national or government policy going into regions, how do you ensure that this will survive a general election? How has it been anchored with different sides of the party? But this is a long-term commitment. And do we have any thoughts on that, very briefly?
Well, in fact, it has survived to 4 ministers of health. So it's been a long time. It was the COVID pandemic in the middle, so it took quite a long time to get it. It has survived to 4 ministers. The key is to get engaged. What we call the committee. There's the scientific committee and there's the technical committee, in which all administrations were involved. So all the steps that I mentioned before were evaluated by the administrations, and they approved. Actually, one of the few strategies that actually all the steps were approved unanimously by all the administrations. If we don't have the involvement of administrations, there's no way to do it. It cannot be a top-down approach. It has to be, let's say, a network approach. So I think the part of the success will be relying on that they understand the same way that we do, that we have to go that way.
Very interesting. Thank you very much. Then we turn our eyes to Poland. Dr. Przemysław Mitkowski, who is professor of cardiology in Poznan. You're also the president of the Polish Society of Cardiology. Please, let me hear your thoughts about this. What's the take in Poland and in your society around this?
Let me start from some background. You know, the health debt, cardiac debt, existed before the COVID pandemic. During pandemic, we find it is even more important. According to our data, we find that cardiovascular deaths were by 17% higher in the first year of pandemic in comparison to 2019. And of course, those deaths were beyond the COVID-related deaths. Probably it was caused not only by the system, but also because there's some resistance of patients and they wish to avoid the contact with healthcare system to avoid infection. So many procedures were postponed, and patients we've got after this first phase of pandemic were in more severe diseases. Moreover, last year we find more than 150,000 deaths in comparison to last 50 years of average. Moreover, scientific societies in Poland are no longer the only scientific societies. So are not only responsible for the education, for science, or for guidelines or any statements. We have to talk to authorities, and we do this during various panels, but also during our conferences. So we also propose some solution to solve the problems related to cardiovascular care. One of first, our success was to establish a few years ago a program which is called Managed Care for the Patient After Myocardial Infarction, which consisted of 4 pillars. First, acute phase and total revascularization. Afterwards, very quick rehabilitation. Afterwards, suitability for the device therapy. And in the end, various consultation with nurses to change everyday habits, to support the therapy. And finally, after 12 months, we find that we managed to reduce mortality in those who participate to this program to a little bit over 5% in comparison to a little bit less than 9% in those who are not participated. The next program, which was established as a pilot program by the Ministry of Health in the cooperation with cardiac professionals, was the cardiac network, which covers 4 fields in cardiovascular medicine: heart failure, arrhythmia, valvular heart disease, and secondary or resistant hypertension. It is more or less the same which was established for managed care on the level of primary care physician. We have hypertension, atrial fibrillation, heart failure, and ischemic heart disease. According to the data, because you know this managed care after myocardial infarction was not only the therapeutic and diagnostic program, but also scientific one, we find unfortunately that after 12 months, only 18% of patients receive guideline recommended therapy for the reduction in cholesterol level. And also, we managed to achieve the target goals after myocardial infarction, I mean 55 milligrams per deciliter, only in approximately 20% of patients. So now we propose to establish a new pilot program with 10 selected centers to have very early intervention to reduce more cholesterol level. And finally, a year ago, we established a national program for cardiovascular diseases. It would be supported by the Ministry of Health
with quite, I think, nice amount of money, because it would be for the 10 years around 700 million euro. Of course, it is beyond the regular reimbursement for any procedures, any medical services. And this program will focus on 5 fields. The first is medical professional education. It is really important because, of course, when we calculate those who prescribe receipts, we have a lot of physicians. Unfortunately, majority of them work only part-time, so few hours a week, and of course cannot be calculated as a regular cardiologist. The second is prophylaxis. So change of population habits, reduce burden of the risk factor. The third one is patient in the center. So establish some programs to diagnose risk factors like hypertension, diabetes, like elevated cholesterol. In Poland, we calculate that elevated cholesterol, because of this, suffer around 60% of the population. So it is quite huge number of people. The fourth one is science and innovations. As far as the drug, we have some problems. Nevertheless, from the EMA approval, we have on average 2 years until the therapy is approved and reimbursed. For the device therapy, it is more than 5 years. So unfortunately, they are available, but not used on the regular basis. And in the end, system changes, which are also very important because sometimes very cost-effective changes in the system could give us some more profits.
I think this is really, really interesting. You're pointing to some really nice both suggestions, but also I see some problems here. How do you manage the problem I always see is the gap between primary health care and hospital care? It is easier to sort of streamline hospital care. So how do you manage that?
It's an extremely good question. Because, you know, in this cardiac network program, which try to fulfill these 4 fields, we have several of them which are the same as for the primary care physician. So we try now to make them parallel. According to this cardiac network, the idea is to put final diagnosis from the suspicion within 30 days. So the first contact with a professional cardiologist within 30 days from the initial diagnosis, and afterwards a treatment or more diagnostic. The second one, we would like to change a little bit, or revolutionary, the role of cardiologist, who should no longer be responsible for the therapy as a physician who take care directly, but rather as a consultant. It is very important. And of course, we collaborate very closely to the primary care physician specialist, and also with patient. A lot of our events, which are conducted by the Polish Cardiac Society, are also dedicated to patient. And during our Congress of the Polish Cardiac Society in autumn, we have on the last day in the afternoon special session with patient. It is called the Congress of the Patient Heart, and we will have the 4th edition this year.
That is really...
So, you know, it is not easy, but we have to talk with other specialists to harmonize care.
That is fantastic. Really, really impressive. Thank you very much. I think we'll have some more discussion and question around this. Then we move to the beautiful city of Prague and to hear Professor Michal Vrabrik, who is Professor of Internal Medicine in Prague, but you're also the chairman of the Czech Association for Preventive Cardiology. What is the view from Prague on this?
Well, I must say this meeting is really fulfilling my expectations because it gave me so much food for thought, the introductory session and also what I heard from Professor Mitkovsky. Basically, we are at the same grounds, I believe, and we share common troubles, common obstacles, common barriers. I really loved the introduction from Birgit, who reminded us that without planning, we will fail. And I'm really proud that basically 10 years ago, we published our first national cardiovascular plan that those days was focused on acute cardiovascular care. And, you know, I can be proud of the system that enables every Czech citizen, but also you as visitors will receive the same service, that within 90 minutes of occurrence of your clotted artery, you get Revask procedure. And it's perfect. And we do have mortality currently at the rate of 6.5% within 30 days after NMI, which is a good standard, I would say. Though there are regional differences, and I'm coming back to the first session, data and the use of data to improve care. And only very recently, like half a year ago, we started the first benchmarking project to show the differences in mortality rates at 5 days, 30 days, and 90 days between the heart centers. There was quite a big opposition. Colleagues were afraid, you know, because somebody needs to be the last, and no one really wants that. But no surprise, the Earth didn't stop moving when we published the chart. And the last ones really started to think about the differences. What's crucial, there's no punishment, but rather incentives for those who are at the bottom of the chart. What are the reasons? Do you need more staff? Do you need more money? These are the questions that actually removed some of the reluctances, some of the fears from those who were against putting the heart centers on a chart. So I would say that acute heart care is at a very good standard in our country, and of course it can be improved, and we are going to be working on improvement. But what we really see as a huge need now is to start working on another edition in 10 years of Cardiovascular National Plan that is going to be much more focused on preventative measures. And I was really keen to hear the words from Peter, who basically told us about the data, and I believe data is the power. And I also loved Fredrik's point that basically you inquired 300,000 people and got 10% response rate. Did I get it right? Mm-hmm. Yeah. 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 Okay. So they kind of volunteer. They subscribe to your call. For last 25 years, we've got a system of preventative checkups that's reimbursed from the general reimbursement to every citizen of Czech Republic, every second year of their life, from birth to death. Unfortunately, only 50% of our citizens actually regularly participate at this. So basically everybody has the right to know the basic data, the basic values, cholesterol levels, blood pressure levels, even blood glucose and hemoglobin A1C levels. But people are not interested. And I really loved hearing from Thomas that who is the health, whose responsibility is health and health status? Is it ours? I have patients who come to my office, sit down and say, "Oh, doctor, I lost some weight to comfort you, to make you happy." And I look at them and I say, "Make me happy?" No, that's wrong assumption. You're doing it for yourself, not to comfort me. Of course, I'm pleased that you've improved, but you should be pleased at the first step, at the first line. So this is something we need really to work on. And this is a question that I really don't know the answer to, because we've provided a lot of space, a lot of opportunities really to move the field forward. But unfortunately, it seems that our regular citizens are not very much interested. And Thomas, actually, I heard you said once, I am not interested in something. And I understand your point. On the other hand, that's very bad news to me, that you're not interested in what something about your health is right or wrong. And this is very much beyond our power, I would say, and therefore I liked actually the minister's introduction, and very many colleagues speaking here already told us that it's about collaboration. We have to go beyond. We are healthcare professionals. Of course, we know what should be done, and we can definitely discuss it with our partners. But without partners in the field of education, in the field of even Ministry of Labor, for example, because basically if we take good care of the health of our patients, they can work longer. They can provide more economic, let's say, incentives to the system. And these arguments have rarely ever been used, but I think that without this interconnection, we will fail. So therefore, we are now establishing a broad group, and I really love the introduction of Professor Buena, who also said they collected 100 individual panel, which is enormous group to manage. Congratulations that you did it. And without that, we will fail to really proceed, because if we really get stuck in our pond of healthcare, we perhaps can't improve very much what is currently the situation right now. So I think that there are really very many ways how to improve. We of course need to know, and I'm really very keen that for the first time we've got a system where all the data go to one institution. It's called Institution of Health Statistics and Information. So basically everything is stored there. They have all the data, but they are reluctant to share them because they say they're overwhelmed with, and last time it was the COVID excuse, because we're overwhelmed with COVID statistics, so we cannot provide you with the data about this and that. But now we've got a promise, because we basically published the intention to create new cardiovascular plan from 2023 to the perspective of 10 years. So the director of this institute promised to give us all the data pertaining cardiovascular field till mid-May.
Okay.
Yeah, I'm saying it publicly. This year.
Okay.
I hope this is going to be recorded, because now the entire Europe knows that Professor Dušek promised us that. So it's the 10th promise. So we'll see. But without the data, we perhaps won't be able to move on. We also need the data not only to get navigated what is the most important field, but also to get people convinced that it's really something that needs to be done. And I'm really very happy for this Healthier Heart meeting here, because we are once again putting CVD on a stage to the center of our attention. Most recently, we've heard so much about cancer, and I'm definitely not underestimating the moves and the proceedings in the field, but CVD is still a life-threatening disease. And it is not less threatening than cancer. So I think that we really need to do something about it.
That's really, really very well spoken and really interesting. I have one question that might be a bit mean to ask you in a short time to answer. But as we are moving more and more against prevention, you even said that everybody have a right to have a checkup every other year. We will, I think, face the problem about the participation of the healthy. So it is the healthy, the educated people who will participate. We've seen that in many studies. How should we address this when we are moving more and more towards prevention? How do we actually motivate all of us? I mean, not all of us to do this.
When did you have your last preventive checkup?
I was thinking about that. I don't know my blood pressure, so it's an eye-opener, but it's true.
Well, I participated in a study as a healthy control, so I know the numbers now. But that's a crucial question, and maybe we need to get the advice from social workers, social sciences, psychologists, and this is what we are actually. They are also members of our group, because basically we don't perhaps have the necessary knowledge here. What is the motivating, triggering factor? And we need really to bring these people on board, and that's an innovative approach once again. It's not about cardiologists only. It is also about the people who work in the social sphere.
use all the expertise we have in our
Absolutely.
region. That's very good. Thank you very much. Now we go to Professor Antoine Bondu, who is a cardiologist and head of department at Hôpital Erasme in Brussels. But you're also the president of the scientific committee of the Belgian Heart League. What's your take on this, Professor?
Yes, thank you for your kind invitation to this very interesting meeting indeed. I would like to summarize a bit of action plans at the level of Belgium. So Belgium is a very small country with a lot of hospitals, so we could think that we could have a lot of data on cardiovascular disease, but the answer is no. So in fact, at the Belgian level, we were quite surprised to have national data about the cause of death. And indeed, we realized that cardiovascular disease is the main cause of mortality just followed by cancer. But once you want to have data on the risk factors and the control of risk factors, we realize that in fact at the Belgian level there are data somewhere at the national level, but not actionable, not readable for the national societies like the Belgian Society of Cardiology, neither the Belgian Heart League or the other scientific companies that we have in the country. So we have the vision that cardiovascular disease is a major problem. It's an important problem in our country, of course, like all over Europe in the world. But we have a real big problem that we don't have tools to action to promote cardiovascular health. So I really enjoyed the previous talk on that way. And what we did at the national level is that we start a national plan on cardiovascular disease, and we put together the Belgian Heart League, the Belgian Society of Cardiology, the Belgian Heart Foundation, but also the National Committee on Hypertension, and also GPs and pharmacists, because we believe that in Belgium we do not use enough the first line in managing cardiovascular risk factors. And so we address this problem on that way. So we did, based on this group, a roundtable at the Belgian Parliament with stakeholders, trying to show them indeed what is our reality as healthcare providers, and indeed the fact that we definitively need more actions to make those data available for all the actors, and even for the person themselves, in order to promote cardiovascular health and to promote a better knowledge of the risk factors control in Belgium. And I would say that from that point of view, if you want to get data and have a clear vision on cardiovascular disease in Belgium, in fact, the only way that we achieved to have those numbers was to do a roundtable with experts and try to evaluate what would be the number of ischemic heart disease, cerebrovascular disease, and peripheral artery disease. So it really means that we could not rely on those numbers, and we need to have a better registry available for all the healthcare providers involved on that way. So I really enjoyed the first part of this meeting, highlighting that we definitively need accessible and continuous database that could provide to all of us indeed data that we can use to promote cardiovascular health, that we can use also to monitor our actions in order to promote risk factor control. On that way, we tried, because in Belgium we were also investigator in the EuroAspire registry. We have Guy de Bakker here in Belgium, which was one of the leaders of those registries. And we tried to make sub-analysis of the Belgian reality regarding the control of cardiovascular risk factor. And we have to admit that, in fact, there is still a gap in control of cardiovascular risk factor, and you can consider smoking, blood pressure, diabetes, weight excess. There is still a lot to do in order to promote cardiovascular health on that way. And the difficult thing was to realize that if you compare EuroAspire, EuroAspire 3, EuroAspire 4 registry, there is no clear change of the control of cardiovascular risk factors among time. So it shows that what we do nowadays is completely insufficient to increase the control of cardiovascular risk factors. So we definitively need more action at the national level, but also from the European level to make of this point a clear priority. So our vision is that indeed prevention and primary prevention is a very big challenge in our country. We definitively lack data that we can action to promote cardiovascular health. We are also a bit surprised to see that when you see all what is invested in the field of cancer in terms of prevention, there is no such reality in the field of cardiovascular disease. And we should, I think, underline that those cardiovascular risk factors are, none of them is difficult to control and to treat. So they are easy to detect, easy to measure, easy to know, and easy to control with treatment. So I think we need definitively a better awareness of the population regarding those cardiovascular risk factors. And so we hope, and at least that's what we are fighting for at the national level in Belgium, that we will have access to a national database or even European database that will allow to have a better vision on the control of cardiovascular risk factors. We hope that our stakeholders will also put in front of their agenda various strategies to increase the health resources that are allocated to adherence to risk factor detection and control. We hope that we'll have some societal program dedicated, by example, to schools or to media campaign in order to promote awareness regarding those cardiovascular risk factors. So in Belgium, we don't have so much action on that way, and this should be, I think, support even maybe at the European level. And of course, an important challenge is drug accessibility, and that indeed our national constraint for prescription should definitively fit with the international guidelines at best, we hope. So in our vision, we definitively, it's of course an history of cardiologists, but this is of course, it's for us an history that should concern every healthcare provider, starting from the first line. And for this national cardiovascular plan, we involved, in fact, the pharmacists, which are for us an important player, that have a lot of contact with the patient and even the persons, let's say it like this, for primary cardiovascular prevention. We involved a lot the GPs and of course all the national societies, and we hope by this way we have at the end a plan that will allow us to reduce the burden of cardiovascular disease in Belgium. So having said this, I'm very happy to read that there are, to hear here that there are many actions that are taken at the European level, and I think it's by this way promoting those actions at the national level and having a European structure that give also us a power to make those actions concrete. That I hope that we can change stuff for in the coming future.
Thank you very much. That's really, really insightful and interesting. We'll start the discussion. I have a question for you first. We're talking about, you explained very elegantly that Belgium is a geographically small country with a lot of hospitals. Sweden is a huge country with not that many hospitals. There's always a risk when we are talking about European data that you can always explain away the data. They don't apply to us. We can't compare because there's always an explanation why we can't do it. So how would you address that? Because I think most of the things are common. You can tweak them to different countries. How would you address this? That everybody thinks they are so unique and have unique problems, or is it that way?
I think it's a real challenge. I think indeed a country like Belgium, we have three regions with at least two different systems. The data are sometimes kept in two small entities. So I think it's important to have national or European plans that allow to have a common framework. I think the framework should be common in order to have actionable data. But then how you will use them at the local level, or if you take from the European to the national level, of course, the way you will use them won't be exactly the same. But Belgium is one of the examples where indeed, let's say, kind of complex political country, we realize that there are data available at the national level, but no spread beyond the national level. So it's definitively a big challenge, I think, for our country and also for Europe.
Yeah, thank you. Emma, do we have any questions from the audience yet? No? Then we can ask you. How you said, I mean, the data, they hurt when they really affect you, and that's when you start acting. I mean, Peter and I were working as cardiologists when the first Swedish data were presented of the ranking of hospitals, and we were all really, really worried about this. But it did actually make, you were also working, Maria, there, so but they actually made us go one step further. So
I truly believe that this is going to happen, and we've got a very nice example at our neurology community. Basically, intensive neurology centers also started this benchmarking a couple of years ago, and nowadays the last ones actually are fighting to be better, and they decrease the door-to-needle time by 10 minutes in a couple of years, the worst ones, to just get closer to the best ones. But while Antoine was talking, he reminded me of one thing, and Hector also mentioned it can't be done top to bottom. It must be networking. But on the other hand, the top backing, if you wish, is very much necessary. And it reminded me of a story. In our country, we've got 22-year tradition of following up community of FH, familial hypercholesterolemia patients. We've got a registry, 10,000 registered individuals out of 40,000 expected. So pretty good success, third in the world in the detection. And we actually talked to our politicians. And during the EU presidency, we organized a meeting at the Senate. And actually, this was the key word that reminded me of the story. And we organized a Senate session on FH, and that it would be desirable to implement universal screening for familial hypercholesterolemia as the most frequent inherited metabolic disease with cardiovascular consequences on a European level. We asked our European colleagues to come. The event happened. And all of a sudden, there's an interest. We live in a PR era. If you don't do PR, basically nothing really happens. So nowadays, the field has started moving, and there's quite a number of European countries who've adopted this Prague Declaration, and they are now working towards implementation of universal FH screening. So this is a success story, and we really need the backing from the top.
And a success story on a European level, which I think is interesting. We have a question from the audience, I think.
Yes, we do. And this is a broad question for everyone. Why should a European CVD plan be written and approved?
Professor Bueno, would you like to start this? Why should we do this on a European level? Why not stick to national levels? Or should we, maybe?
Well, I think what is critical to change the society and to change the healthcare systems, anything, is leadership. And the UE has the leadership. So, of course, we need national plans because every country has different situations, different healthcare systems, different needs, different epidemiologies. So at the end, it has to be landed in each country. But the leadership is very strong. And I think as much as they have done a cancer plan, it would be extremely important to get in people's mind, because I think we have to move out of the healthcare system. We need to get into the society. We need to get into schools. And I think the leadership of the European Union is essential. That's why we need a European plan. Of course, then each country will need to adapt to their specific needs. But leadership is essential to make big changes.
Yeah. Professor Mitkowski, any thoughts on that also?
Yes, I think that nothing can influence a political decision beside comparison to the other countries. Because when we have a common plan, so we also talked during our spring meeting and other meetings with the board of the European Society of Cardiology, it is important to focus on special problems which are somehow common in Europe. Nevertheless, you are living in the south, north, west, and east. Because afterwards, we can obtain some money and try to do something. We can put our goal. For instance, we would like to decrease the percentage of patients with non-controlled hypertension, on elevated cholesterol. And you know, these are parameters which are very easily comparable. And we can say that our efforts in Poland are not so good because we are in the bottom fourth of the countries in which we could obtain our goal. So I think it is very important. What is also important, we should talk to not only patient, but also to society. Vast majority, if not all, cardiovascular risk factors does not produce any discomfort until atherosclerotic cardiovascular disease became symptomatic. I am really jealous about the Czech Republic because we have also established plan to perform some risk factor checking for the population over 40 years of age. Unfortunately, not 50% of population, but only 10% of population follow this program. So it's a real problem. And I think that we have to also involve the media, television, radio, some social media, to show patients that they should be co-responsible for their health, especially when they retire. Because when you are talking to the young person that they will probably die, it means nothing because their grandfather died, not them. But the quality of life in the future is very important.
I think that's very, very good. I think, unfortunately, our time is coming to an end there. It's been a very, very fascinating discussion. And what I think we should take away from this is that we have our great European Union. We have so many good examples out there. And we have to remember that we are all more than one person. We are here as professionals, as politicians, as patients, but we are more than that. I mean, I might be a patient tomorrow. I'm also a taxpayer. I used to be a physician, and we all have this. And we have a whole gold mine out there. The problem is that the nuggets are scattered over the union. If we put them together, we will get a great gold bar here that we can use. I think we will take all these really, really important messages away, and let's keep this discussion live. Maybe we should do a follow-up on this, because I think this has been fantastic. Thank you, everybody, the panel foremost, and also all the listeners. Thank you very much. Now I'm handing over to Petter again.
Really amazingly interesting to listen to all of you. It has fallen upon me, with some help from my friends, as it's called, to sum up and maybe to some extent look forward after this afternoon. And I welcome Victoria Zuma to the floor. You are, in your everyday life, international cardiovascular health policy lead at Amgen, but you're also co-chair of the FPIA cardiovascular health platform. Talk more about that. And I have on the screen Jenny Nordborg, head of international relations at Lif, the Swedish pharma industry organization. And for many of us, still, Jenny, you have to excuse, you are the almost just recently life science coordinator for the Swedish government. So really thankful that you are here with us. I was actually Victoria, you're the chair of FPIA cardiovascular platform.
The co-chair.
Yeah, co-chair.
The chair is here. Christy and Donkey.
Hello, Mr. Chair. What is that, and what are you doing?
Yeah, sure. So the FPIA Cardiovascular Health Platform is a disease group of FPIA, which is the European Federation for Pharmaceutical Industries and Associations. We are a group of 10 companies already who have an interest in R&D for CVD. And our vision is to address cardiovascular disease and to reduce mortality for cardiovascular patients in Europe. We believe that there is a strong urgency at the moment for healthcare systems to address this. The mortality data we also heard today are not looking really good, although the last 30-35 years, there was a decrease in mortality across the globe. Now we've seen these mortality rates plateauing, but also in some European countries, they are even increasing. So this is really worrying, and we need to address this. Especially in the aftermath of the COVID pandemic, I think it is really important because we heard that that cardiovascular patients at a very great risk of death and complications from COVID, but also another important point is that their quality of life has been severely affected. So from the FPA platform's side, we are doing so. We are trying to co-create policies on secondary prevention, on early detection, on screening policies that can help achieve better cardiovascular health outcomes. And we are doing so by partnering with healthcare systems, but also with other important stakeholders, such as the European Society of Cardiology, the European Heart Network, and also the European Alliance for Cardiovascular Health. And that's also something that is important, I think, because it is an alliance that we are participating in, but it consists of 17 major organizations that work on CVD, on the CVD space in Europe at the moment. And we are also advocating for a European cardiovascular health plan, as a lot of our speakers referred to.
Yes, I've been noting that has been a common theme through the day. And I mean, to some extent, I mean, we are here inspired by the fact that Sweden is now president in the Union and so on. If we take that broader look at the European Union as a policy actor, what are your expectations of the Union? What could they bring to the table?
So I will first talk about the European cardiovascular plan, but I have in mind the European Beating Cancer Plan that Hector Bueno also referred to, and it was last year. It was published by the European Commission, and it provides recommendations, actually. So it is not a regulation, because I think there was a question from the audience. It provides recommendation for countries to implement at national level for cancer. And cancer is the number 2 disease, killer disease at the moment in Europe, and cardiovascular disease number 1. So one should ask, why shouldn't there be a European plan for cardiovascular disease, who actually kills most men and women in European countries? So this is quite important for us, and we are working towards that direction in our advocacy work. We also, in parallel, we're also asking for a joint cardiovascular and diabetes health checks to be implemented in European countries. We think, this is a screening policy which is really simple and easy to implement. It can be done at primary care level. We heard from the Czech Republic that they are already implementing it. Of course, we need to do some awareness around this, for sure, for the public. But these checks, we've seen that they are really very cheap, very inexpensive, and very cost-effective. So we really need to invest now in screening policies so that we have better outcomes in the future and save costs as well, because we realize that healthcare systems are in financial restrictions at the moment, for sure. But this is a very easy policy to implement. And we did an event at the European Parliament in collaboration with the diabetes community in the end of February. We actually invited politicians, members of the European Parliament, to speak about cardiovascular disease and to discuss with other stakeholders, so with healthcare professionals, with patients, with researchers, and also with industry members around this. And they all actually acknowledged the fact that there is really insufficient political commitment at the moment, and that more policy actions and political actions are needed in order to have better cardiovascular health outcomes in Europe. So we are hopeful that this will happen. And my last point would be that we heard from Mr. Ryan from the European Commission about what they are doing at the European Commission level and the European Union level. We believe that it is great. The EU Healthier Together NCD initiative that includes CVD and provides recommendations to the countries, and also the funding through the EU for Health initiative. But we believe that we need to make a step forward and actually for the European Union to adopt Council conclusions on the health checks that I just mentioned, and actually ask from countries to act upon this and recommend these health checks to the countries.
Jenny, the same question to you, and maybe from the Stockholm perspective during the Swedish presidency, expectations for this presidency and the Commission and European Union and Council going forward. From your point of view, what role could the European Union play or should play?
I think it's been a really great discussion here today. Now, really to reflect on what could the importance of a sort of a joint plan and vision be. And I think that it was raised many times really to set the common framework and to set the common goal and to be able to follow up. And I think that that is some of the important learnings that we have both from the Swedish perspective, the Swedish cancer plan and the European cancer plan. And that was raised in the cancer conference earlier during the presidency, really the importance of setting clear goals to be able to follow up to see where we are now, but also to be aware of that this takes long time. We can't implement the plan and then say a few years down the line that now we've done it, sort of. And I think that that is very, very true in the case of cardiovascular disease, that it's a culture shift and it's shifting of behavior that is needed, both within different professions, but also within society as a whole. So I think that this is an area where cross-border collaboration is extremely important, not only between sectors, which is of course important between industry policy, academia, healthcare as such, bring the patients around the table really to be there as a strategic partner, but also to have the within European, amongst the countries' learnings that you've been showcasing here today during the discussion. I mean, learning from good and better practices, even though it can't be translated to your own system, it's really on the follow-up scheme where we can see that how we make progress.
Thank you, Jenny. Is there any other, we've been discussing a lot of different aspects of this huge area, cardiovascular health. I mean, it's really a societal issue, as someone said, not only in our healthcare pond, it's broader than that. Is there any other area of those we have touched upon today where you think that the political leadership, for example, from a European Union level is necessary to push things forward?
I think that from this perspective, cardiovascular disease is really an area where health data comes into play in a very concrete way. And that's also been raised many times during the conference, the importance of really utilizing the longitudinal registries to be able to follow up, but also to be able to use health tech tools for immediate follow-up and implementation. So I think, in my view, in the implementation of the upcoming European health data space, it's also possible for the cardiovascular area to be also a forerunner in piloting and implementation of that. That would be something that I would really wish for from this community.
Thank you. We're talking about political leadership, and we heard a lot of interesting examples, I think, from the latest panel about the national perspective and how to structure some kind of national plan. I think there are many different iterations of what that could be, but this importance of it, I mean, we all needs to be something collaborative, but it also needs to have some driver and political. I think from your helicopter European perspective, Victoria, do you think these ideas of national plans is a good way for other countries other than those we heard? Is it something that you see as a key lever for doing things?
No, definitely. I think what we've heard today from Spain and Poland is actually amazing. I wish more countries could draft these plans. Of course, the important thing is for these plans to be implemented and be successful, right, eventually. I think one of the core aspects of both these plans are that they include prevention and screening policies in their main cardiovascular health strategy. So I think this is really important for countries to think about. And of course, and this is also, along the lines of the ideas of the health checks. But of course, as Jenny said, I think collaboration is really important and sharing these best practice examples. So, for example, Poland and Spain could teach Sweden, on how to draft a plan, and from the other side, Sweden could actually provide important learnings, to the rest of the countries in terms of utilization of health data, in terms of how they built this Swedeheart registry. We've heard amazing stuff today, like these registry-based clinical trials, which I didn't know about, so that's really, really great news. But first we need to have, I think, the basic stuff, learn from each other, see, where the gaps are for each country. And I think this is, and it is also very important to set specific metrics and specific targets for each country so that we can follow and monitor them. But it is also really important for countries to have allocated budgets for cardiovascular health plans. So this is why I think also European cardiovascular health plan would be important, because it would set the basic recommendations, and then each country could actually pick and choose and learn from each other.
I was thinking about this both in registries, and Peter was describing the Euroheart, and I was kind of disheartened, but I think it's quite telling that they build something new on a European level, but this is coming from the ground up. It's industry, it's professional associations and so on doing this. At the same time, politicians in the European Union talk about, as you said, the European health data space and so on. But there seems to be kind of a lack of a political leadership with more hands-on things. Could that be kind of one focus to actually support these kind of pan-European health data projects a bit more hands-on, not just these broad plans? I don't, Jenny, what?
Well, I think that before there's sort of really hands-on on a systemic level, we need to really utilize what is already happening. So I think that the conclusion that we're heading for is that strategic plans and overarching frameworks are very important to make things happen in a speedier and more holistic way. But until we have that, we have to utilize the bottom-up approach, because that is already happening.
Yeah. Do you have any comment, Victoria, on that?
I think as a last point, I think an important thing to mention is health inequalities. We've heard so many people talking about health inequalities at, within the countries, but also, from the European Union perspective. And the data for health inequalities in CVD at the moment are not looking really good. There are a lot of inequalities between Eastern European countries and Western European countries in terms of CVD mortality. There are a lot of differences in the way women are managed with cardiovascular disease are managed versus how men with CVD are managed. And there are a lot of differences between populations with different socioeconomic backgrounds. So this shouldn't be happening in the European Union of 2023, right? But political commitment, as you mentioned, is, I think, has a very important role to play with regards to that. And also then countries need to invest in good policies, right? And so we need to see health as an investment and not as a cost, as I mentioned before. So we need to invest in good policies in order to be able to save costs for the future, but also save the lives of the European citizens.
Martin, you were talking about in your panel about the prevention work and getting in touch with the actually right people, not only the healthy ones. And I think that's so really interesting. I saw some analysis you were mentioning, Victoria, the decrease, well, the fall in mortality in Europe is decreasing, is flattening out, and sometimes, and to some extent, different in different countries. And I think I've seen analysis that this is an important part of that is the socioeconomic inequalities, that we don't reach deep enough into the population. And so I really think that's one of the things in many aspects that we need to have in mind.
Yeah, I think it was also mentioned by Professor Hector Bueno, but also from other people, that it is really a social issue, and we need to tackle this. And this is also political decision making.
It is. Thank you, Jenny and Victoria, so much for helping me closing up this and reflecting on what we have heard today. I want to thank all of you for coming and joining us physically or digitally today, and of course all the speakers. And definitely also thank you to the companies that have made this possible today. Amgen, AstraZeneca, Berger, Novartis, Novo Nordisk, and FPA and Lif, who are both contributing and hosting this event today. I was just thinking about Göran Hägglund kicked off the day and set a bit of the tone about really perhaps the need for a refocus or reignite the fight for better cardiovascular health. And he drew the comparison with the Swedish cancer plan, which he was the father of. And we talked a lot about this need for political leadership. And just maybe my personal comment then is we've heard so many things which really shows what we can do. And I'm thinking about this country of cardiovascular health, what we actually could achieve for the inhabitants in that if everything went as it should, if all good examples spread. So my goodbye note to any stakeholder, policymaker listening is to paraphrase the great Fredrik Söder and using instead the Nike slogan, maybe it's time to just do it. And with that, thank you so much for today.